Hello again, a very warm welcome to everyone. Thank you for making time today to join our final Our Community, Our Health Town Hall of this year, talking about the CDC pandemic grant to vaccinate the community. My name is Carolina Rosales. I've had the pleasure to serve as the Pandemic National Site Coordinator for the past 3 years and have seen this grant from its close to the beginnings to its now end. Of course, we like to say that things don't formally end. I'm sure we're all taking away things from this project that you'll hear in these upcoming sections from our amazing panelists that are coming from all over the country, different parts of the country here today, talking about the pandemic grant. So for those of you who may not be aware of what the pandemic grant is, very fun acronym, a CDC-funded project that University of Florida led, a fun acronym that stands for Program to Alleviate National Disparities in Ethnic and Minority Immunizations in the Community. So really serving to bring vaccines and services to people where they are, addressing vaccine hesitancy, building trust with community members, and doing so, as I mentioned, by meeting people directly out in the field via mobile health vehicles. We'll hear a little bit about that today. Community health workers, we'll touch on those pieces, and really leveraging community partnerships that we have strengthened from prior work to work towards that greater goal of getting shots in arms, as we have said. Before we begin, and I pass it over to our panelists, I will just put up some brief poll questions, a pre-town hall set of questions, and you'll see some at the end as well. So if you all wouldn't mind just taking a moment to go ahead and answer these brief questions that you'll see pop up on your screen, that would be greatly appreciated. Thank you all for that. Okay, so rolling right into just, again, a pandemic overview. Really just wanting to highlight, we don't have individuals from all of our different partner sites, but I did want to give quick shout outs and credit where credit is due to all of our amazing partners that we worked with directly all across the country, namely Albert Einstein College of Medicine, University of California, Davis, Florida State University, University of Kentucky, University of Minnesota, University of Missouri, University of Texas Southwestern, and of course, Health Literacy Media, who are joining us here today as well. I just want to highlight some brief site metrics. I know we talked about vaccinations in the beginning of this call. So just looking at what we have been, some, of course, of what we've been able to accomplish in these past 3 years, we have nearly 30,000 survey of perceptions, which we'll hear a little bit more about on this call as well. Over 4,000 outreach events to different parts of the country via our outreach events and at our different sites. Over 10,000 referrals that have been given directly to different community members at all of these events. Over 12,000 COVID vaccines, over 2,000 other vaccines that have been administered at these outreach events as well, and over 50,000 community members that we have reached as meaningful contacts. Of course, we've seen many, many more than those numbers in attendance, but just some brief spotlight of some of what we've done through this work. So excited to get into hearing different experiences of different roles, what those have looked like from out on the field, from designing different communications as well for this project. So with that, we'll pass it over to each of our panelists. They'll speak for roughly 5 to 7 minutes, and we'll ask you all to save questions towards the end, or feel free to drop those in the chat or in the Q&A box if you see that as well. So without further ado, I'll pass it over to Lynn Warnicki for her to introduce herself and get us started.
All right, great. Thanks, Carolina. Hi, I'm Lynn Warnicki. I was the program manager for this project at the University of Kentucky, and I joined this program after it was already up and running. It was still early on, but things were sort of up and running. And reflecting back after when I was invited to be a panelist for this, it gave me a chance to take some time and really reflect back again on what we learned and what were our big successes for this program. I have said from the start, I loved this project. I loved every minute of it. We did great work. I had a great team, and we worked quickly and got things up and running. And when I think back on how we did what we did and how this program will continue, our model will continue to be applied to some other programs at UK, I'm really glad I was able to be involved in it. When I first took the project on, the biggest challenge for me as the program manager was that we were tasked with producing mobile outreach clinics to provide vaccines, COVID vaccines at the time, the first year, but we had no vaccines and I had no vaccine provider. So that was my big challenge that we took on and we had to figure out pretty quickly. And when I first got started, we still had some vaccine providers in town who had sort of popped up to help with the pandemic. But they were quickly closing their doors because they were only set up to be temporary shops. And so at the time, I remember thinking, oh, I'll just work with health departments and, this won't be so hard. But I quickly found out that health departments and retail pharmacies aren't really equipped to do a lot of outreach. So I kept digging and went further and ended up finding a really great partner in one of our local area FQHCs, Bluegrass Community Health Center. And I became kind of reliant on them, and that was a little bit of a slippery slope. It felt like all my eggs in one basket sometimes. But what has worked out really well from that partnership is just that they had the same mission we had, so that was good. We were aligned with what we were setting out to do. I didn't have the vaccines or providers. They did. They didn't have the ability to easily or quickly schedule events or just produce events and get out and deliver the care that their grant was funding. So it ended up being a really great partnership. It was a lot of work. I stayed very closely connected to them throughout the whole project. And I think just part of the key to the success of the partnership, and then just even for both of our programs, honestly, was that we stayed very focused on the program's mission. So for every event that we organized or found to participate in, we always made sure that it was reaching at least one of our populations of focus, that we were providing access to care where barriers existed, that we were reaching people where they are. And we wanted it to be an opportunity to collaborate with other local organizations just to help build a foundation in our own network that could hopefully help sustain the program, as well as, like I said earlier, be used as a model at UK for other programs that had similar structures. And we stayed true to that. There can be a lot of pressure to have numbers and show tons and tons of activity. And, if we were just to go out and set up somewhere really busy and say we have free vaccines, you can do that. But we really tried hard to stay focused on our mission. And, we felt like kind of slow and steady, won our race. So we ended up having good results. We've got really good relationships that have been built from this program. There is going to be a lot of sustainability for us in this area because Bluegrass Community Health Center will continue on, but by helping them build the relationships through the work that we did, that has given them the ability to keep doing what they do. So that's probably one of the things I'm really the most proud of when I think back to this program and how we executed it. We had, gosh, when I say partners and partnership, I mean, it truly took a village. I mean, it was not just Bluegrass Community Health Center and us. We did work occasionally with some other retail pharmacies and UK pharmacy. on occasion as well. But we found a lot of organizations around our areas that were not all that easy to find, but we really worked hard to make sure that we spanned the populations of focus that we wanted to serve, that we didn't just focus on one or two, but that we really did, we went really deep into our Latino communities, our African American communities, and our more urban areas. We were all over our immediate rural areas as well. And we partnered with, churches and Central Latinos and other organizations that served groups that can tend to not be so easy to reach. We worked with a domestic violence shelter, and they were so grateful to have us come in and provide health screens and vaccines and do the things that we did. We worked with a group that worked with adults with disabilities, elderly, people that lived really remotely and didn't and had transportation issues, things like that. We also tried to find partners that could bring other services that were relevant. We found some areas that had a desperate need for Narcan supplies, and so we found a provider for that. We always tried to bring a little bit more to the table everywhere that we went, and I think we were successful in that. And I hope that, the foundation we built can continue on and that these organizations can continue to work together and reach back out to UK for other groups and programs. And, hopefully they had a good experience with us as well. And that some of this can live on through programs like this. Um, so from a project management standpoint, that was our approach. And really just a lot of the lessons we learned, building trust within these tight-knit communities. It is possible. It takes time. It definitely takes time. And you just have to, have a sincere interest in working together as partners, even with the people you're serving. That was very much appreciated. And, I learned myself that not everyone can or knows how to access healthcare, even if it's free. So meeting people where they are was so critical. I've become pretty passionate about delivering preventative care through these means, and I hope that I can continue working in that space as well because it's, just offering it and saying, if you offer it, they will come. That's not always the way that it works out. So the delivering care to people where they are, I just think was probably the biggest lesson that I learned through this personally. Um, and last but not least, I mean, preventative healthcare is just desperately needed and wanted. I don't know that I interacted with anyone, even when people were a little bit hesitant with COVID and reluctant and they weren't sure those early, weeks when we were working on this. Um, taking the time and to work with people as a partner and not even just providing a service really opened a lot of doors for us. And I feel like when you work in the public health space, just figuring out how to work in that space and fit in and build those relationships, that is key. But all the services we offered were very welcomed. I've had a lot of phone calls about, can we continue, when can you bring your vaccine clinic to me? And I've handed them off to our vaccine providers. And like I said, hopefully these things are continuing on and can sustain because by year 3, I wasn't having to call anybody. They were all calling us. And that was just such a win, in my opinion. So, and that's it. I don't want to take up too much time, so we can pass the mic.
Thank you so much for that, Lynn. So many great things that you said, especially talking about sustainability, that infrastructure. If you know Lynn, you know the powerhouse of a coordinator that she is, and all those behind the scenes coordinations of hitting a dead end and pivoting to try to make sure that those services are present. So it is my pleasure to introduce another powerhouse of a person, Diane Bernacki, over here at UF.
Hi, everybody. My name is Diane Bernacki. I am the CTSI CRV team leader, nurse manager for our team. Our team consisted of an operations manager, another RN, a driver, and myself. And then I have to say everything that you said too. It was a great project. I loved every bit of it. I loved doing community service and community engagement. We, unlike you, did our own vaccines. So we did a hospital base where we set up with Florida Shots and got our own contract and worked with our medical directors here at the CTSI and got our own vaccines. And we went out, the two nurses went out and we did our own vaccines. So we did not partner with any retail services or anything else. We found that we were able to roll out much, much quicker that way. So what we were able to take away from that was that we created a whole new system on a mobile that included standing orders, protocols, SOPs. We are EUA ready now that if anything else comes up that we can roll out because we have the contracts with Florida Shots. We also learned how to do vaccine storage and transportation. We were able to get certain coolers that were approved by Florida Shots. Working with logger systems. We learned all kinds of things. We worked with our IDS pharmacy out of the CTSI that managed to take our shots and record them into Florida Shots every single day for us. So we did a lot of shots. We did a total of 1,752 shots in the last 3 years that just the two nurses did out in the field. We also offered health assessments, which included like blood pressures, cholesterol testing, blood glucose testing, BMI. We added that assessment on along with the vaccines, which was wonderful because we were able to address a lot of hypertension in the community. We collected data through our RedCap, not with any PHI information, but what we did is we collected like zip codes, what the blood pressures were, what the cholesterols were, so we can go back and collect the data in those certain particular areas and see what their particular needs are. So if we can move forward, which we hope we can, because we've built wonderful partnerships. We've served over 20 counties in Florida, North Central Florida area, with 12 of those events being reoccurring. So we are just loved the program. We did. We were able to build trust again, like Lynn said, in our communities in a very difficult time. COVID was a very difficult time to build any kind of trust, but yet we were able to do that. We still have that trust in the communities. They are all wishing we could come back for the next 5 years. And we're hoping that we can find grant money to continue this endeavor because I think it's very, very much needed in the community. It's been a great partnership. We did learn a lot about vaccine hesitancy. We were not widely accepted in some of our counties. Taylor County here in Florida would not even carry COVID shots in their DOHs. So we would try to go into the counties, but Taylor County here in the state of Florida was one of those that didn't actually want us there. But we tried. We went, I think, probably 5 or 6 times to Taylor County. So it was interesting learning about the vaccine hesitancy that was occurring also, and trying to break the barriers to get through to get people to see how important is that these vaccines were. We also added on onto our COVID vaccines. We also added on flu vaccines, and we did about 590 flu vaccines in the last 2 years, along with the COVID vaccines that we were doing and our health assessment. Our health assessments, we totaled about 2,200 health assessments during this time too. So we felt like that we hopefully made a difference in these communities, and we want to continue to do so. I think it was a great foundation for building trust, and I hope it will continue. It will continue. Yeah, I'm very glad to be part of it.
We're glad that you were a part of it, Diane. Thank you so much for that. Double yay, as we see in the chat as well. And of course, none of this work at all would be possible without different community members or community partners who are doing the same thing and meeting people out in the communities each and every day, helping out with all those coordinations. So it's my pleasure to pass it over to Bruce Waite from the Melrose Center to kick us off for our next section.
And thank you for inviting me to participate in this today. A little bit of quick background. We are I'm the executive director of Common Thread International, which began as a nutrition and metabolic disease field research organization. In 2010, 2011, we built an intergenerational community center in Melrose, Florida, which is in Northeast Florida, where 4 counties come together. And the census tracts we work with are homogeneous in that they experience some of the poorest health outcomes and highest level of metabolic syndrome in the state. In 2000, we built the center in 2011. In 2016, informed by 6 years of my USDA sponsored field research using a mobile vehicle called Fresh Wagon, we developed 4 pillars of service. We look at healthy nutrition, healthcare access, social connection, or the abatement of isolation, and economic sustainability. In 2018, after retiring from field research, I assumed the directorship of that center. In 2020, April 1st, we were shut down by the state of Florida, as all non-essential businesses were. And we immediately pivoted and converted the operation to a mask factory where we provided first responders with masks that we sewed with community members. And also we continued to hand out food through a window in the wall. In the fall of 2021, we formed a medical reserve unit under the Florida Department of Health. And in 2022, in December, we held our first 2 large vaccine events, which was 580 individuals at each event. And of course, shortly after, in May of 2022, there was a pretty large shift in Department of Health policy concerning field inoculations. And having had the pleasure of having significant colleagues in the College of Public Health, I was able to reach out to both Linda Kotler and Diane and her team. And the 2022, under the Department of Health, we ran clinics in 2000, as well as continued to have, under the pandemic grant, we had Health Street attending our events and helping us with community engagement. In May of 2022, in 2023, we pivoted, and Diane and her team took over the full responsibility of supporting us in vaccinations, at which we have continued, as well as continuing our focus on metabolic disease and basal health. We continued that until our last group large session, and our sessions were 80 to 120 people, which we held bi-monthly or as needed, sometimes more than that. We ended up, when the EUA expired in 2024, that was our last event. Really, a lot of we learned a great deal. First of all, I guess COVID was way out of my discipline and academic interest, but I had some extremely good mentorship. Dr. Kartik Cherabati took me under his wing and taught me how to work with vaccine hesitant individuals, and that worked very well. We developed a navigational cohort of 1,000 people, which we still maintain today and provide navigational services on a monthly basis. The one of the things we learned in developing our MRC is we recruited individuals who lived in the neighborhoods where the people we were targeting lived. And they were charged with developing community champions, ministers, and other community leaders who then assisted us in building a network of trust. We and again, we learned through navigation to keep extremely close contact with our cohort. So we spoke to them, and our clinics functioned entirely by appointment. We did accept walk-ins because once we were engaged in vaccination, people would wander in off the street. But our core was, and we would vaccinate anywhere from probably 4 to 8 people an hour, depending, and sometimes more, depending on the nurses. And then one of our team would call everybody a day later in the beginning to make sure there were no adverse reporting. We did extremely extensive sentinel surveillance. Because of our relationship with the health department, we were able to get a considerable number of like pallets of rapid tests. We distributed those throughout the community with the understanding that people would notify us when they tested positive. We distributed O2 meters, and our teams would call people 2 or 3 times a day. We partnered with the local EMTs, and our understanding, and again, to set the stage, our local funeral home by then had parked a cooler truck in the back. The wait time for the EMTs to arrive was 4 to 6 hours, and they would sit in front of Shands or other public hospitals for up to 12 hours before even allowing people to walk in the door. We had never fathomed this magnitude of acute disease. We also by having this covenant of diversion with the EMTs, the understanding we had, and of course we would check everybody's O2 status, and if it dropped below an acceptable level, the understanding was when we called the ambulance, they came. And so that worked beautifully, although, we are within our cohort we were about 94% fully vaccinated. To put that in context, the census tracts we work in range between 3% fully vaccinated at the low end and about 12 at the high end. So we tracked 911 calls with the EMTs, and the areas we were serving had some of the lowest COVID emergency calls in the community, but we still had the highest rate of metabolic disease. We learned in this process to combine our services so that we continued to work with metabolic syndrome and other behavioral or nutritional diseases, as well as and continued to provide those services to the same population we were recruiting for vaccinations. We did not use or did not seek any grant funding, although we were heavily supported by the pandemic grant, by the Department of Health, but we really found that we could pivot a lot more quickly when we weren't trying to work within the construct. So our entire effort was funded by the community, and who came in and participated. We have some support. We have a support organization that sells arts and crafts, and we also we're a licensed 50-seat restaurant. the proceeds from that go to support, even to this day, our health program. We were able to vaccinate in partnership, both with Diane's team and 3,800 people. And in a town that has 500 residents. So, we've learned a great deal. And one thing we've learned is to, keep our eye on the horizon. And as I said at the beginning of when we were chatting, we're looking at the horizon right now, and we're maintaining our ability to rapidly respond for our community. No matter what the pivot in health policies coming, we're a community that now understands that we've got to build the village we want to live in. So, we walk away with a lot of lessons. We realized it did not take a lot of resources to do what we did because we had really good friends who had money and resources. But one of the most important things that helped us was our sentinel surveillance, because we could target our outreach efforts to a finite level, not based on demographics, but based on patterns of transmission. And so we were able to move our resources to neighborhoods. I mean, we have neighborhoods we serve that have no telephonics, no internet access. And the only way we could access people was working through the churches and working through that infrastructure of our community health workers. But anyway, that's my story. I mean, I don't want to use up too much time, but.
No, not at all. I think all of us could hear the rest of that story for the whole entire time of this webinar. So
Yeah.
thank you so much for sharing all of that. Extremely
Sure.
impressive, and a true testament to the persistence and importance of collaborations, for
And
sure.
my thanks to both Diane and her team and Linda and Health Street, because without them, none of us would have made it.
Definitely. Thank you so, so much.
Yeah.
And with that, we'll pass it over to Dr. Nikki Eater.
Thanks, Carolina. Nice to hear these accounts of participating in the pandemic project. I'm going to provide a perspective as a site leader at the University of Minnesota. Some of what I'm going to say will resonate with comments that are already made, and I'll try to point that out. And the goal is to tell two very brief stories and then try to connect the two stories, and hopefully it'll make a little sense. There were 10 practices, strategies, promising practices that were identified at by the project team, and we pursued a particular strategy which is titled Promoting Health Equity Through the Cooperative Extension System. And I think every state in the country has a state-funded institution with a cooperative extension system. We being the medical school at the University of Minnesota, had never partnered with extension before. And I had been involved in the clinical and translational science project at our university as the director of the community engagement activities. And I thought that instead of creating a set of relationships for this project, it would make sense to partner with Extension, because they're already out in the community and they're doing this work of engaging the community. A lot of what the Extension program was about was financial literacy and also agricultural support. So adding a health component to it was the goal of our collaboration. The other reason that Extension was very attractive as a place to work is for the reasons that everybody was who presented already on this call was talking about. It's very difficult to get out into communities that are under-resourced, and both to share information and also to provide access to vaccines, because I think, as Lynn pointed out, it's not always readily available, even though the state or county health departments advertise them or pharmacies advertise them. People don't always feel comfortable going into those kinds of spaces. One of the biggest centers that Minnesota had for vaccinating people free of charge was at the Mall of America. So it's a kind of a challenging place to get to, and not all that different than some of our healthcare, academic healthcare centers, where you park and you walk for a half an hour to get where you're going. Extension was great. They had a gardening program already in place, and what we were able to do was a combination of two things. One was to plan additional events, primarily vaccination events, where we were the beneficiaries of all the relationships and trust that had been created between Extension and these various communities, primarily in South and Central Minnesota, Spanish speaking to a great extent, so not necessarily the focus of the county health departments always. And they were able to bring people out to events. And when they were having already established events, there's a Hispanic business expo once a year. There were church events and all kinds of other things. They were kind enough to allow us time to both talk about vaccination and other health-related issues. So we were able to piggyback and I think, Lynn, our hope, because not only people supported by pandemic, but ongoing faculty at the university and in the medical school were enlisted to go out. And for example, if we're having a gardening session, we invited people to come out and talk about the danger of ticks and how to be safe, because it's a big issue in Minnesota. We also had the dermatology department have someone come out and literally make a 10-minute presentation to people who are outside gardening and to talk about the value of skin protection. And so these were additional activities and add-ons to the issue of discussing vaccination. And I think that from a sustainability point of view, the question of access to vaccines is certainly up in the air right now. And whether or not we will have, my concern is that our county health departments have informed many of the people on my team that they're going out of the business of administering vaccines. So if you don't have a regular source of care, it becomes a challenge. I may be going on a little long, Carolina, so wave at me. The second story, and I'll try to be very brief, is that we were also collecting surveys of perceptions, which people have mentioned. And we went to the state fair for 2 years and collected data. And one of the interesting things is that you can imagine that people that go to the state fair, imagine the state fair is like a ritual activity. People go every year, they have emotional connections to it, but they also feel both financially capable of doing that and that this is a public space they belong in. And I would almost make an argument that we could say this is a kind of an informal community, because it is a kind of ritualized activity. There are a lot of shared expectations to it. And what we learned from the survey is that 85 to 90% of our population has access to health care. We also found out that, unlike the national sample, people are far more trusting of the medical, not only of doctors, but of vaccines. So 70%, which is a really high number, were enthusiasts in the persona that we've been thinking about. And what that means is they wanted to get the vaccine as soon as possible. And I would say that one of the reasons for that is that these are individuals with a regular source of care, access to a doctor. They have a personal doctor. 90% of the respondents said that they had not had to defer care for financial reasons in the last year. So if we go back to the group we were working with through extension, it's almost on the opposite end of the spectrum, where these are populations that don't necessarily have health care. They're easily preyed upon by people who want to share all kinds of information. Some of it may be accurate, a lot of it not. And I think we were very fortunate that we enjoyed the trust and the relationships through extension that allowed us to put a program on without building something and then worrying that at the end of our funding it would go away. So I'll say one last thing. It was an interesting dialogue with our extension partners because they're used to getting program support. And program support often comes with a quota. We need you to recruit 120 people, and then you will have met your deliverable. And one of the things we visited regularly, we discussed, and which I believe will help sustain some of the relationships we were able to put in place between the medical school and extension, is that we recognize that there is far more need than there is resources to meet the need. So that we committed collaboratively to working together consistently and not just towards the number of people we initially set to get. And I think it's important to just remind people that that is the floor and not the ceiling of what we should be attempting to accomplish when we go out into to do public health. I thank everyone at the University of Florida and all of the other institutions and people on this call because I think collaboratively we can say that we've genuinely accomplished something. So thank you, Carolina, for the opportunity.
Definitely. Thank you so much for joining us. And of course, I'll pass it over to Dr. Katina O'Leary to close us out today.
All right. Can you guys see my screen?
Yes.
All right. I'm going to talk for just a couple minutes, and I know that everybody didn't do slides, but I wanted to do just a couple to give you some examples of what we are doing. And of course, as usual, it's not going to just show me right away. But I'm Katina O'Leary. I'm the president and CEO at Health Literacy Media. We're a community-based nonprofit organization. We sit in St. Louis and we work all over the world. And I've had the opportunity to work with Dr. Kotler for years and years and have been fortunate to work with a lot of folks as part of the collaborative and then join here for this pandemic initiative. And so I've been lucky to be here since the beginning. And we did all the health literacy work. We did the health communications work and we supported the team. So I just want to tell you a little bit about the work that we did and show you some examples quickly. I want to say always when I start, what is health literacy? Very frequently when we talk about health literacy, there's some confusion and people think that we really mean individual health literacy, and we start to talk about what community members should do better to understand health information. And we want to clarify that what we mean is that we use a cross-disciplinary, evidence-based communication best practices to guide professionals and community members to use information to make informed decisions. So this isn't about making people different or smarter or making it easier for health professionals to not give them information. It's about sort of blending communication across all the people that need it and use it so that we can have good conversations and people understand the questions to have asked and they understand from a level playing field how to communicate about their health. So that's what we've applied here as a real evidence-based practice to help everybody understand. And this is a big deal because most of us, frankly, misunderstand health information, especially when we don't feel well. And COVID was a great example of times when nobody felt well. We were all confused. We were all sort of struggling to understand our risk, which is, of course, one of the most complex pieces of health information anybody could understand. And it changed depending on where we were and what we did and sort of where we were born and where we were sitting, the parts of the country, the kinds of jobs we did, all of those things. And that's hard to communicate. It's hard everywhere. And then the vaccines came in on top of that. So the statistic often talks about 93 million American adults lack the health literacy skills they need to use their health information. But the truth is, it's all of us all the time. Another sort of misunderstanding when we talk about health literacy is most people immediately go to readability, and they talk about getting materials or information down to a 6th or 8th or 4th or 5th grade reading level, whatever it is that the university or other institutions have decided. So whenever I talk about health literacy, I need to remind folks that readability is the basic piece of information. We certainly want everything to be readable and as readable as possible. And we have to remember that literacy levels are different depending on your age, of course, your education, and all kinds of other factors. When we live in different parts of the community, we may use different words or jargon, and we have to think about that really careful. But that's the base level. That's the foundation, is everything should be readable at the most low-level literacy possible to still be understood and clear. But beyond that readability, we have to think about plain language. So we can make the words simple, but they still may not make sense. So plain language just puts them together in such a way that they make sense and they're clear and people can understand. And it may be that it's written content, but also verbal content. So however we're going to do that, we layer plain language on top of readability. And on top of all of that is health literacy. And when we do that well, we have images or video, multi-format content, all kinds of ways that people can use it so that it comes to them in such a way that they can read it, understand it, hear it, put it in context, and make good decisions. So just keeping this in mind as we talk about health literacy is really important. So quick example, this is what health literacy can look like. It's not just about words, and design isn't just fluff. So using simple words in plain, clear language that makes sense together is piece one. And thinking about where we can use design and graphics so that people can follow along with content and make good decision is really important as well. And for many of you, you probably realize that when folks have lower literacy levels for any reason, the visuals, the graphics are cues for them to determine whether a material or a message is for them. And if you leave those out, it doesn't work. So this is an example about Alzheimer's disease and dementia. But why we use this example is it shows the assessment piece. It shows a question. It uses a lot of format to work people through a document that is really a guide. And then it explains what the guide's going to help you do. Know the difference between these things, learn what people know, decide if you want to do this, and call and reach a point the action item. So it's not just sort of pushing out a bunch of information like the educational brochure content draft on the left. It's more of this pulled together piece to help people follow along. So again, Carolina talked a little bit about what pandemic was and the components of the activity. So we were pretty active in all of those components. We worked with each of the partner sites to make sure that there were two pieces, that we had everything we needed for the overall activity for the whole partnership, the grant, but also the individual sites had sort of tailored pieces. And if you look at the map, you can see very clearly that these folks are all over the country. And what that means is their needs for their communities were very different. So we could put together a standard flyer, but when we started to talk about what people needed in Kentucky versus California versus Missouri, sometimes there were these little changes that needed to be made. Some of them were large based on language and other things, but some of the things were pictures or things like that. And so we needed to be available to help people think about how to make that work so that the flyers, the posters, the materials didn't get overlooked and thrown away. We wanted people to recognize them as meaningful for their own use. So we spent a lot of time in that way. And our role was to create plain language materials for the grant to promote health equity and better health outcomes for everyone in the communities. We created 515 plus plain language materials that were multi-format. So that means they weren't just pieces of paper and flyers. They were fact sheets and social media messages and videos and whatever format we heard from our community partners would be helpful. And we translated those into 11 languages. And again, that was coming from communities, what languages were relevant and necessary to meet their community needs. So what do we create? These are some examples. These are fact sheets and infographics. And one of the important things to talk about here is, we didn't only talk about COVID, we talked about flu and other things while we were out because we heard from community that was a draw for them. Sometimes COVID was a message that was sort of outside the limits for some communities. But if we talked about flu or other things, we could have a conversation that led to a COVID conversation that didn't feel as scary. So while sometimes things look outside of scope, they're necessary for scope to engage community. So this is an example of what one of those look like with flu vaccine. The other thing I'd ask you to notice is the images. These are more animated characters. They're not real people. We have a lot of conversation with this about with partners about whether we use real images or we use these more cartoonish like images. And I say cartoonish, but you'll look and you'll see these aren't childlike. But what they show is a woman, for example, that you can't exactly tell what her race or ethnicity is. You may not even be able to tell if it's a female person. So the gender is a little bit androgynous. It's not completely screaming female. It's not screaming anything, but it allows people to sort of look and say, okay, this might be for me and not throw it down immediately. You'll see that all the characters across both pages are very different from each other, and they all represent things that are relevant for public health. So you'll see the bandage on the arm or the masks on or vaccine or any of those things. All of those things sort of help signal to people what we're talking about. You see the use of QR codes. We all learned to use QR codes quite early in the pandemic. You see that on the first page where it says scan or click to learn more. We use this often so that we could give people one piece of paper or one link, but connect them to a bunch of other resources. And we found that was really useful. And you'll also see as you go along that these are pretty big graphics, lots of tables, lots of color. We tested these to make sure that they were not so complex people couldn't see them, but they could use it to sort of follow along in different sections, and it really jumps out at people. And again, getting at this lower literacy level, people who don't read as well really function better when the information is spaced out. There's less information on a page, and the graphics help them navigate through the image. So you'll see that in everything that we created. I mentioned before multiple languages and multi-platforms, but these are some of the social media posts in 11 languages. So an example of Albanian, Bengali, and languages just all across the board here. But you'll see with each message, it's not only the translation, but the image changes too. So you can't just change the words and leave the same image because people know that that's not really for them. So you have to be really thoughtful about what people look like in their community and match the image with the words. And so we've done that with all of the social media. More educational content. So this is an example of a video series focused on reasons to wear a mask. Yet again, a set of characters that look very different, short videos. This one happens to be 2.5 minutes. There was a lot of content. Typically, we would ask for 90 seconds or less to get people to fully watch a video, but we needed this particularly early on for the masking reasons. You also see with most of these multi-formatted educational content pieces, we would have a video and we would also pair it with something like a flyer or a handout so that people didn't have to watch or have both. Or if they watched it, they could take what they watched and then walk away with a handout and show it to somebody in their family or use it as a memory tool to reinforce whatever message they learned. So that was really important to us that they had pieces for both. And again, some people don't want to sit and watch 2.5 minutes, but if you don't read well, being able to listen for 2.5 minutes and then walk away with a flyer could be really helpful, and it sort of structures and helps folks understand. And then the last thing I want to say is we use the website quite a bit. So at the early part of the grant initiatives, we put together a website and we used it to house all of the materials so that folks could go from the sites and get them, but they could also point people in the community back and they could share them more broadly than just our site and field folks. So if folks at health departments, doctor's office, clinics, whatever, wanted to access these, they were available to everybody in the community. And as I mentioned, having the 11 languages, this was a big deal because many communities don't have materials in that many languages. They may have them in English or Spanish or one or two other languages, knowing that some of the bigger communities may have people that speak many other languages. So having these resources where they can go back and get something that they know exactly what it says in English, but they have 10 or 11 other languages to look at can be a real asset for communities. And we found that people really appreciated that. And I will stop now, but I appreciate having the time to give you just a few thoughts from a health literacy perspective. And I really appreciate the ability to join the group and thank Linda and Mickey and the team for having us.
Thank you so much, Katina, and to all of our panelists, of course, and participants who were able to join us today. I know that we are right on time, so I unfortunately don't think we will have time for Q&A questions. I don't see any in the Q&A chat, so hopefully no one's question was missed. I know we were given lots of things to think about and mull over about how we can take away different aspects of this work and continue that on to future projects. I think each panelist, of course, stressed the importance of meeting people where they are, but also just overall sustainability in the work that we're doing and collaboration. I think everyone was sharing similar sentiments that the work wouldn't be possible without one another. And so just focusing on that again, a big thank you to everyone on this call who may have been involved in pandemic work or who is involved in community engagement work to some capacity. It's been an absolute joy to have coordinated this project for the past 3 years. And of course, a big thanks to Dr. Linda B. Kotler, who I see on this call, for spearheading and for her leadership for these past few years and to the future as well. All right.